Hello, everybody, and thank you so much for joining us today for this, I think what will be a really interesting panel on linking health and human rights. I'm Justine Nolan. I'm the director of the Australian Human Rights Institute at UNSW Sydney, and very happy to be co-hosting this event with the Human Rights Law Centre. I'd like to begin today's session by acknowledging the Bejigal people, who are the traditional owners, custodians of the land on which UNSW sits, and also confirm our support for the Uluru Statement from the Heart and the substantive mechanisms that it proposes to support the First Nations people. So today we're going to be looking at how and why and what we're doing to make the right to health a reality in Australia. The right to health really has never been more in the news than in the last 18 months. I mean, many of us are probably sick of hearing about all things around health, particularly around COVID and all that entails. But the right to health is really an intrinsic, right that is really intrinsic to our being. And it is so interrelated to many other human rights as we've seen over the last year, particularly the right to life and the right to work, to name just two. The right to health is formally recognised in Article 12 of the International Covenant on Economic, Social and Cultural Rights, to which Australia has been a party since 1975. But this right remains largely often unfulfilled in Australia. The right to health is reflected in the provision of public services in Australia, but such services cannot be claimed as a right and can be withdrawn at any time. So the panel today is here to explore a little bit in more detail this right, its application in Australia. We're going to try and draw out some both good and bad examples of its practice, and also ask what difference it might make if we had a national charter of rights and freedoms, and how perhaps our right to health might be protected a little better. The Australian Human Rights Institute has joined with the Human Rights Law Centre and other leading rights organisations in Australia to campaign for a national charter of rights. And we believe that a full right to health should be recognised in the charter so that everybody can access quality healthcare when they need it, regardless of the context or the background. I'm also happy today to launch the Human Rights Institute report on making the right to health a reality. This short report provides an overview of the human right to health, how it applies in Australia in the Australian context, and also examine how its implementation might differ if acknowledged as a right to health incorporated in a national charter of rights. I'm very proud to say that this report has been authored by 4 of our students at UNSW who've been working with us on this. So my thanks go to Lubna Sharif, Alicia McKenzie, Alfred Nguyen, and Rabiba Pervez, who have written the report. And thanks to them, you'll find a copy of the report on our website, and we'll also post a link in the chat so you can find it. So let's go to the panel and start our discussion today. Our first panelist is Donnella Mills. Donnella is a proud Torres Strait Islander woman with ancestral and family links to Masig and Nagi. She's director of the Wuchopperen Health Service. She's chair of the National Aboriginal Community Controlled Health Organisation and a member of James Cook University Council. Donnella is a Cairns-based lawyer with King Wood Mallison and the project lead for the Wuchopperen Health Service. Our second panelist is Rosemary Kayess. Rosemary is a senior research fellow at UNSW's Social Policy Research Centre, a senior lecturer at UNSW Law and Justice, and associate of the Australian Human Rights Institute. She's the chair of the United Nations Committee on the Rights of Persons with Disabilities, which monitors the implementation of the Convention on the Rights of Persons with Disabilities. She's also the chair of the Australian Centre for Disability Law and was an expert member of the Australian government's delegation to the UN in negotiations for that convention. And our final panelist is Hugh Kretser. He's the executive director of the Human Rights Law Centre since 2013, and Hugh was a board member before that from its establishment in 2006. Hugh started his legal career at the law firm Mallison's and then began working to protect and promote human rights as the manager of the Brimbank Melton Community Legal Centre and the executive officer of the Victorian Federation of Community Legal Centres. I'm going to pose some questions to the panelists, but we really want this to be interactive. So if you have questions or comments that you might like to make to the panelists, please post them using the Q&A function, and I'll try and incorporate them as we go along. But we really would like to get your feedback and questions as we go along. So in the meantime, let's start with my first question to Donnella. Donnella, it's been said that Australia's health system is one of the best in the world, and we have seen it come under pressure in the last year in particular. But it's generally recognised as providing quality, safe and affordable healthcare. And it's a key reason, it's argued, why Australians enjoy one of the longest life expectancies in the world. Do you believe this is true for Australians as a whole, or just a select few when we look at the right to health through that lens?
Before I move to answer your question, Justine, I too want to acknowledge that I'm very blessed to live on the homelands of the Gimor-Wallaburri Indingy Nation up here in beautiful far north Queensland, Cairns. And I want to pay my deepest respects to their elders, to my elders, and to all of our elders. And I also want to say strongly and proudly that I recognise the strength, the resilience and the capacity of Aboriginal and Torres Strait Islander people. Answering your question, health equity. Well, if I can start by saying that it's true for most, but not all Australians. Most Australians can look forward to one of the longest life expectancies in the world. People in Bangladesh and Azerbaijan must be quite envious of our healthcare system and our health outcomes. But people in Bangladesh and Azerbaijan have longer life expectancies than Aboriginal and Torres Strait Islander people in Australia. So when I say that it is true for most Australians, it is certainly not true for our First Nations people. People in my own family, my community, have 9 years less to live than other Australians. We have a polarised set of health outcomes in which Aboriginal and Torres Strait Islanders are lagging behind the rest of the population. We are, and I just want to sort of put context behind this, Aboriginal and Torres Strait Islander people are 5 times more likely to die from rheumatic heart disease, 3.7 times more likely to have kidney disease, 3.2 times more likely to have diabetes, twice as likely to suicide as young people, and twice as likely to die from respiratory disease. If we put aside the obvious reasons, such as systemic racism and the ongoing impact, legacy of colonisation, there are 2 main reasons, and both of them have to do with funding and the lack of it. We need to look at the burden of disease for Aboriginal and Torres Strait Islander people. The Commonwealth Government itself has the burden of disease measured at 2.3 times higher than the rest of the population. And in remote communities, that can be 6 times higher. So that gives an example of this enormous chasm of divide of where health equity sits. Currently, the Commonwealth spends $1.21 per Aboriginal and Torres Strait Islander person for every $1 spent on the rest of the population. So when I refer to the burden of disease being 2.3 times higher, just that general maths gives you the idea of where there is this enormous difficulty in meeting their need, addressing the issues without the correct funding. The second reason, low health outcomes around social and economic disadvantage, which of course is captured in the 16 socioeconomic targets in the Closing the Gap. So socio and economic targets like housing, health, education, justice, I mean, the list goes on. So if I could just start by putting that forward as a starting point to understand that for Aboriginal and Torres Strait Islander people, the idea of having the same health outcomes of the rest of Australia, just that difference in life expectancy paints a really strong picture.
Thanks. I mean, that's a really important context to start with, and we're going to come back to that and look at, sort of how we, address that and sort of suggestions around what should be done around that area. But Rosemary, Donnella has highlighted some gaps in quality healthcare. In terms of your own experience, your own research, what else have you seen? What other gaps would you highlight in terms of the provision of healthcare and the implementation of the right to health in Australia?
For people with disability, they're fairly basic gaps and barriers that people with disability have to access healthcare. And it's about the real fundamentals of being able to get through the front door, being able to engage with the equipment, being able to get into dental chairs, be able to get up onto examination tables, information about healthcare not being in, effectively accessible communication modes and means, consent mechanisms or denial of autonomy to make decision around health decisions. And so that's about accessing primary healthcare. Donnella powerfully, pointed out the fact that the mortality rate, the mortality age for men in Aboriginal communities is far lower than the Australian population. Well, the same is true for men with intellectual disability. And a lot of the time, it can be as fundamental about as not having access to primary health care. Because what happens in disability is nothing is considered outside the disability. Everything within disability is considered special, as if it's something fundamentally to do with your disability, and lots of very basic primary health care things can get overlooked. So people can die from abscesses on their teeth when they've got a disability and are not able to get, the system isn't able to communicate with them effectively enough to get to what the issue is. And so there has not been a cohesive, well-structured, funded national strategy to make the health system more accessible for people with disability. Other complicating factors are there's a significant divide between general health and mental health. Different frameworks, different laws, different funding streams and governance frameworks. And people with disability, people with psychosocial disability are just a subset of people with disability. But this is not often the focus of people with disability having access to mental health. And this is really true for people with intellectual disability. And it's very difficult for it not to be seen just as part of their intellectual disability, when actually it is a very, very different health situation that needs to be dealt with. And they have had significant issues in trying to gain access to mental health services. And there's also the barrier that is created around the coercive nature of the mental health system in Australia and around the world. It's repeated in many countries, and it ends up being forced detention, deprivation of liberty, denial of physical and mental integrity. And it's all based on a very benign, benevolent, protective guise of mechanisms that view mental health as dangerous and demonised in many ways. And there's a huge impact in terms of the psychotropics on people. And so there's more a focus on that highly medicalised chemical response to people with psychosocial disability, and less input into looking for alternatives that don't require coercive mechanisms. And so people avoid the healthcare system because their primary diagnosis overtakes and people don't look at the fundamentals in healthcare, primary healthcare, and just focus on the disability. You can then get the other end of that scale where people with disability, their primary diagnosis can actually cause complications for primary health issues. And healthcare workers, specialists and GPs alike, don't understand some of those complications. And so the person themselves has to become, their own mini registrar and be able to identify what the complications potentially could be if people, want to go down a path of treatment. And so what that does is it means it keeps funneling people back into specialist services. And so you can't just go to the GP and get assistance. It becomes a much more complicated process.
Yeah, so I mean, Hugh, what we're seeing just with these opening comments from Donnella and Rosemary is this sort of discrepancies within the healthcare system within Australia, whether it's targeted at particular communities or there might be thematically, a division between physical and mental health as well. I mentioned at the start that the right to health in Australia is largely seen through the lens of a provision of public services rather than a rights-based lens, which means these services can be withdrawn at any time. And there's not this perhaps framework of services of how we might assess the needs and the problems that both Donnella and Rosemary raise. Based on your sort of experience and research, what have you seen about the implementation of this right in Australia that perhaps might be inconsistent with the international framework for understanding what the right to health means?
Thanks. And I'd just like to acknowledge I'm meeting on Aboriginal land that was never ceded. In my case, it's Bunurong land here in what we now call Melbourne. I think Rosemary and Donnella have pointed out very compellingly that while Australia performs well on a world scale overall in terms of our healthcare system, we have real problems with health inequality in Australia and sharing the benefits of that system across all of our population groups. And so that they've talked about the health inequality for Aboriginal and Torres Strait Islander people, for people with disabilities. You could look at health inequalities for people in rural and regional areas across Australia, people in aged care facilities. The Aged Care Royal Commission is pointing to often horrific outcomes for elderly people in Australia in those facilities. For people in immigration detention, and particularly in offshore immigration detention, we've had someone who has died, Hamid Karzai, from a basic infection that wasn't properly treated and died from that infection. We've got a coronial inquest ongoing at the moment into the self-immolation of someone on Nauru who and that inquest will look at access to mental health services in offshore detention, which have been proven to be awful in terms of their impact on people's mental health. So we have a good system overall, but we have intense inequality within that system. Prisons is another example. Prisoners don't have access to Medicare and so have very differential treatment to differential access to health services. And what a right to health would do is properly implemented in Australia is change that dynamic from being one of service provision from government to saying government decides what you shall receive to one where you actually have an enforceable right and government has to properly consider and act compatibly with that right in determining how to set up the policy parameters for healthcare in Australia and also how to best deliver that healthcare to the Australian population. And in preparing for today, I looked and at the, I think there's a Charter of Healthcare Rights, which is a non-enforceable statement of principles that people have access to. Originally, when it was first published, it actually referred to Australia's international human rights obligations. That's since been removed in the latest version of it, which was published in 2019. So on the one hand, government is saying to people who are accessing healthcare services, of course, you have a right to access healthcare services according to your needs, and you have a right to access services of a high quality that are safe. But government isn't properly holding itself to account in terms of that quality and that access. And so that's what enforceability of a right to health would do. It would say government has promised under the International Covenant of Social, Economic, Cultural Rights to respect the right to health. That means government should progressively realise that right within available resources. Each of us should have the highest attainable standard of mental and physical health, yet the Australian government and state and territory governments, with a limited exception of Queensland, we can talk about that, have not properly implemented that obligation into Australian law, and so they're not holding themselves accountable to that standard that Australia has promised to comply with on the world stage.
So let's go on from that in a moment, and I'll come back to the sort of the solution-oriented focus as well, particularly Donnella and Rosemary in a moment with some of the things that you raised. But what I'm looking at some of the questions, thank you for putting them in the Q&A as you go along. But one raises the question about the intersectionality of the right to health. And, you know, Rosemary, you also picked up on this as well and saying, you know, how it might impact other factors. And the question in the chat from Anne, you know, talks about the intersections in health inequality in Australia and how it might impact homeless people, Indigenous women, disabled people, and having a look at that intersectionality. To what extent do you feel like the way that healthcare is addressed now in Australia accounts for that? I mean, Rosemary, you talked about this sort of siloed approach to health and its particular impact of persons with disabilities. Do you see that that's a problem with Australia at the moment? And Donnella, I'll come to you next on this question and also potential solutions. Rosemary.
Look, we've got lots of problems with siloing in Australia. We seem to look at people as groups or I think sometimes even tribes that are somehow conflicting, but we all have many layers of identity. And so if we truly want to have a public health system, we need a public health system that is cognizant and recognises and responds to the multiple and intersecting layers of people's identity. And so I find it interesting that we silo things off into Aboriginal and Torres Strait Island, and yet we don't talk about women within that. We don't talk about people with disability within that. We have the disability sector where none of the policy mentions women. None of it mentions, you know, it will mention population subgroups sometimes, but it won't. It will be gender neutral, or it'll be race neutral, or it'll be culturally and linguistically neutral, or sexual orientation and identity neutral. And so we love neutral policy in this country, and that creates siloing until we get responses that respond to the multi-dimensional nature of people. We will continue to silo.
And so, Donnella, I mean, you also raised, you know, particular discrepancies and gaps that affect particularly Aboriginal and Torres Strait Islander people in Australia. And some people might say, well, hasn't the government been focusing on this for years? We keep saying closing the gap report every year. There's no changes. You know, what do you think? Where have we got it wrong? Where's the focus wrong? How would you suggest that change might be advanced in this area?
That's an enormous question.
Yeah, just in 2 minutes, if you could. Yeah.
Okay, so I'll try to put together something that's 250 years against 60,000 years, shall I? So what I would say is what's really important to focus on is what's different about this next iterations of the Closing the Gap is the previous 11 years have shown failure after failure after failure. And what is sitting under that failure is this lack of reform. And that failure was due to the fact that it was things done to us. We were not partners. We were not at the table informing policy. So as Rosemary said, this silo is a government approach. And so what we see in the new national agreement around Closing the Gap are 4 key priority areas. Those first 2, priority 1, shared decision making. That is a game changer, this structural reform piece in the national agreement on Closing the Gap. Priority reform number 2, strengthening community control. So what we have is an agreement from the national level through to local government with a coalition of Aboriginal and Torres Strait Islander peak bodies now sitting at the table informing policy around those 16 socioeconomic targets.
And so that ability, you think that of greater engagement is what's been missing in the past, that, sort of having, I mean, the argument's been out there forever, having input into the so-called solution, not the solution being imposed.
Well, we are now saying to government, we must share power.
Yeah.
We want to share in the responsibility of delivering for our communities. So let's see where we land year after year as the Prime Minister and each minister that holds the Aboriginal and Torres Strait Islander portfolio speaks to the Closing the Gap report. And we have seen some examples, right, even during COVID of that, where we've seen examples of sort of rollout, of certain vaccine rollouts which have actively engaged Indigenous communities, which have had a greater higher success rate than those who haven't. As chair of NACHA, I'm extremely proud to say this every day, all day long. We are the epitome of being able to hit and meet COVID pandemic head on because of the fact of our connectedness. Our art shows, there's more than 550 clinics across this nation. That connection to community was able to translate information. Yes, we have issues around vaccination hesitancy, but what we're going to continue to do is work with our communities to deliver the messaging that is appropriate for the given community. So, Hugh, another question that's come up and something that you alluded to when you made your comments was around what difference a national charter of rights and freedoms might make in terms of the implementation of human rights. And there's a question in the chat which is addressed to Donnella, but also I think it's relevant to Hugh because you raised this issue, particularly raising Queensland's Human Rights Act and the right to health that's recognised in that act. Perhaps what is not well known is that it's not exactly the right to health as set out in Article 12 and doesn't take into account perhaps some of the socioeconomic determinants. But in terms of your response, I mean, do you think that the Queensland Act is a step forward? Does it make a difference? And then what would a national act do and what should that look like in terms of health rights?
Yeah. Thanks. And so Australia's promised to comply with these human rights treaties at international law, but we haven't properly implemented them in our domestic law. We have no Charter of Rights in Australia. It's something we're trying to change. People who want to support the campaign for a Charter of Rights can go to charterofrights.org.au and get behind the campaign. We have 3 Charters of Rights or Human Rights Acts at the state and territory level in Victoria, Queensland and the ACT. Typically, those charters or human rights acts protect civil and political rights. They don't protect economic and social rights like housing, education, health, and the like, food, access to food and water. But that's changing. And Queensland, it was great to see protection of the right to health in the Queensland Human Rights Act. But as you point out, it's a very narrow form of the right to health. It's expressed as a right to access health services without discrimination and a right to access urgently needed emergency medical treatment. So Victoria, for example, while there's cultural rights, there's no right to housing, health, education. ACT has a right to education, a right to work and the like. So we're seeing some changes, but we need to go further by amending and including economic and social rights more broadly in those charters that we have, and making sure we have charters in other jurisdictions and changing it in there at the national level, and making sure we have a charter of rights at the national level. Even though in Victoria, and Rosemary pointed out the particular challenges and needs for the legal system and health systems to respond better to people with cognitive disabilities, the charter in Victoria and the rights that are under it have the principle of least restrictive interventions. There's been some positive cases there, for example, around making sure that courts inquire about special circumstances like intellectual disability or family violence before you jail someone for unpaid fines. That was a charter case that was brought, protected some people and led to a change in policy. There's been cases around challenging the appointment of administrators and guardians to make decisions about who people see, where they live, how they spend their money. And there's been protections that have been strengthened because of the charter in Victoria. But we need to go beyond that, and we need to have a justiciable right to health. In Queensland, it's early days yet. I spoke to the Queensland Human Rights Commission actually today and asked them about the very question that someone from the audience has asked. And I think it's fair to say that while there is a dialogue happening in government around right to health, I think we haven't realised the potential of that right to health that exists in the Queensland Human Rights Act. And I invite people in the audience to contact us, because we are actively looking for ways to give that teeth, to make sure we realise the potential of this. Donnella and I talked about it last week. For example, my understanding is that in Torres Strait, there is good vaccination rates and a good project that has been rolled out to improve vaccination rates against COVID in the Torres Strait. But across the Queensland community, you can see that vaccination rates for Aboriginal people are below average, seeing particular problems in Western New South Wales, where governments are completely on notice about the need to vaccinate Aboriginal communities, the health needs of the communities, the risk of COVID having a disproportionate impact to causing serious illness and disease in those communities, yet we're still seeing lower than average vaccination rates. I think a right to health enforceable would help to compel governments to act appropriately and in a timely way to improve vaccination rates. South Africa has a justiciable, legally enforceable right to health, and we've seen some good outcomes there where courts understandably have been, they give a lot of deference to governments about making policy decisions, but that right to health has still provided important interventions. For example, when the South African government was denying, against all the medical advice, access to antiretroviral treatment for pregnant women to be able to prevent the transmission of HIV/AIDS to their babies. And so as a result of legal action using the right to health under the Charter of Rights or Bill of Rights in the South African Constitution, it was held to breach the right to health, that denial of that treatment. And as a result of that, the government introduced a treatment program for pregnant women and expanded access to those life-saving drugs. And my understanding is hundreds of thousands of lives were saved as a result of that intervention.
Donnella, did you want to make any comment in relation to the Queensland right to health in the Human Rights Act?
Thanks, Justine. Just quickly, as Hugh said, we had a conversation last week, and what my starting point with Hugh was that this Human Rights Act, it hasn't landed in my communities. There is just this enormous gaping hole between actually what happens in community and what's happening in the parliamentary arm, judicial arm, executive arm. And so what's really important is that we really think of ways for community to lead this conversation about the Human Rights Act, for them to feel as though they're in charge of wanting to come forward. So yeah, that would be my response, that these machines that are in operation really just don't land in community, but that's something that Hugh and I are very keen to explore about how we can make sure that that legal education or that information gets in the hands of the people that have the hugest, that are impacted by this day in, day out.
Yeah, and there's a number of comments that are coming in particularly looking at some of these issues, but also the distinctions you raised, Rosemary, at the start around the distinctions between physical and mental health and the lack of recognition sometimes. And this question I'm sort of opening up to the panel, but I'm going to start with Rosemary, is from Lou, and it says, during the course of the COVID pandemic, there's been considerable debate about particular human rights, such as the freedom of movement, privacy, and other civil and political rights. But there's been more limited discussion about the right to enjoy maximum physical and mental health and the need to balance conflicting rights. And how should we recalibrate rights discourse, whether affecting particular groups or more generally, to recognise that rights need to be balanced and prioritised, and perhaps rejigging the emphasis we sometimes make on physical health as opposed to looking at mental health. Rosemary.
The balance, how to balance rights. Sorry, I'll start that again. The need for rights assessment is to be a balance, is a difficult one to communicate. It's funny how Australia doesn't have a big human rights culture, is the best way to put it. We don't talk about it. We don't have a constitution. We don't have an embedded constitutional Bill of Rights. So we don't talk about it with the same nationalistic fervour that the revolutionary countries of France and the US and other countries speak about rights. And it's really quite amusing to see when someone thinks their rights are being infringed, all of a sudden they all come out and they're all rights specialists and they want to gain their rights. And we saw the woman in Bunnings in Victoria, and we've seen the various protests that have been around. And so it's very difficult to get such a nuanced argument across about the need for rights to be a balanced approach. It's about balancing some rights against other rights. Yes, there are rights that are non-derogable, but fundamentally human rights processes are a balance, and it's a balance about resources. It's about maximum extent possible and various other principles and standards. So how you get that argument across and that understanding across, I really don't know. I wish I had the ability to do that, because having to listen to some of the claims of what rights people have and how their right is somehow greater than somebody else's can A, break my heart, or B, absolutely hilarious. In terms of, sorry, Justine, the second part of your question, I went off on a tangent.
I think it was in part looking at the rebalancing between physical and mental health, and there's also a number of comments in the chat around differences between behavioural diagnosis, intellectual diagnosis, particularly in relation to people with disabilities.
The balance between physical and mental health. What happens is we're quite happy to talk about mental health these days in terms as a public health issue. So communicating with the public to try and ensure that they take steps to manage their own personal mental health. What we don't do well is supporting people who have established mental health diagnoses and their access to services, and communicating with them and listening to them about how to manage their health situation So there is a divide between the way we treat mental health as a public health issue and how we treat mental health as a health issue for those that have mental health problems. In terms of being able to, and in terms of intellectual disability and other diagnostic groups, that's just it. We keep talking about disability in terms of diagnostic groups, and we shouldn't be talking about diagnostic groups. There are issues for people with intellectual disabilities in terms of barriers to our community and to daily life that fundamentally can be barriers for many other people with different experiences in life. So what we should do is focus on what the human rights barriers are, what it is that stops all of our community or people within our community being able to access health services and get good quality access to health, and not worry about what the diagnostic group is. Yes, it can inform it, but it shouldn't be, again, getting back to that siloed approach that, oh, this is what you have to do for people with intellectual disability. Well, what happens about the other people with various cognitive disability diagnoses that aren't intellectual disability? Do you not bring them into the room so they're part of the conversation to ensure that they can access health services? So I find, it's going back to, again, to the issue of siloing it. It's really quite problematic to continue to look very one-dimensionally at people.
Yeah, and I think it's bringing in those issues of both siloing, also that diagnostic model, and also what Donnella talked about at the start of this sort of top-down, we'll tell you what's right. That approach hasn't been working, whether for specific groups or across Australia more generally. There's an interesting point raised by Anthony in the chat, which I'll start with Donnella and then go to Hugh. It says, how might the ideas of truth-telling and Makarrata, some of the ideas that have come up, particularly with the Uluru Statement, be reimagined or applied in relation to health inequities, perhaps in relation to First Nations people, people with disabilities, or more generally Australia? Is there a need for this approach? Might it be helpful in how we think about the right to health? Donnella, I'll go to you first, and then Hugh, I'd love to hear your thoughts about this as well.
These questions are really heavy.
Yeah, I'm trying to make them really short and simple for you.
If I can start by saying that I'm very, very fortunate and very blessed to be a signature on the Uluru Statement from the Heart. So I carry that with an enormous amount of responsibility. So to Anthony's question about in relation to truth-telling and Makarrata, truth-telling is, I can't underscore how important it is. History tells this very strong story that holds truth in it in order for us to be able to make these enormous shifts and changes into the future. So the Uluru Statement from the Heart had three very poised asks gifted to each of us around voice, treaty, truth. And so just focusing on truth, we saw the Prime Minister make a very big announcement around stolen generations, the allocation of a substantial amount of money. Again, that's a part of truth-telling. That has been a long, painful, arduous process for my elders to have to stand as warriors to continue to reshape this nation. So I just want to highlight that as one example, how important it is for the truth-telling process, and when government recognises that and makes really solid implementation steps forward.
Hugh, your thoughts on those sort of principles that might be useful about how we think about the right to health more broadly?
Yep, and just congratulations to everyone in the audience, because the questions and discussion and chat are fantastic, and I'm really glad to see the engagement with this critical topic. On truth telling, I think just one comment, it's a big issue and a really interesting issue. I think what it will do is better explain to the Australian people why there is health inequality. If you look at the dispossession of Aboriginal people from their land, the awful oppression and treatment and intergenerational trauma that Aboriginal and Torres Strait Islander people have experienced, it helps to explain and inform why there is health inequality, why there is systemic racism, and the things that we need to do to fix those things will lead to better health outcomes, and the interrelatedness between the oppression and the injustice and poor health outcomes statistically for Aboriginal and Torres Strait Islander people. So I think it helps to build that understanding and the identification of the things that we need to fix to improve health equity across populations. In response to Lou's question, human rights education was the #1 recommendation of the National Human Rights Consultation that happened in 2009 that recommended a Human Rights Act or a Charter of Rights. Their #1 recommendation was human rights education, and Rosemary's point that there's a lack of culture in Australia, a lack of understanding about how human rights principles work. What are human rights? What are my rights? How do I balance them against the rights of other people? So we need to change that. Interestingly, the work that we've done shows, and others, shows that the most popular rights, if you like, in Australia are economic and social rights. When you ask people what are the most important rights, they're less likely to say right to life, right to be locked up unfairly. They're more likely to say health, housing, education, food, water, things like that. Yet there is a disconnect in the rights that we're protecting in law from the rights that Australian people really value and say are the most important to them. And so there's actually an opportunity there to bridge that gap and say, this is what the Australian people are telling politicians is really important to them to protect, yet politicians are not guaranteeing those rights in law, and we need to change that. I'm being very efficient, and there was a good point made about the fact that immigration detention in itself is incredibly harmful and causes the mental health problems. So yes, you can try and band-aid those mental health problems by delivering services to people who are locked up indefinitely. But if you want to improve their health, get rid of the indefinite detention. And we saw that with kids who were on Nauru for years, who are in a catatonic state. The health professionals who were seeing them were just shocked by what they were seeing. With Medivac, with federal court cases, with advocacy, we're able to bring those families to Australia, and we saw incredible transformations in people's health. So that's the power of the law combined with health professionals. And when you look at health justice partnerships that are increasing in Australia, you're seeing much better multidisciplinary approaches where the doctors are saying, oh, we've got problems here, and the lawyers, and these are the things we need to fix to address it, whether it's poor housing or, the indefinite detention, whether it's access to work, access to services and things like that. And then they partner with the lawyers, and lawyers go, well, actually, there's a Discrimination Act complaint there. There might be a Queensland human rights mechanism to use the right to health. There might be a right to life mechanism under the Victorian Charter. So I really want to see more of those partnerships where health professionals and legal professionals and community advocates in spaces like the disability sector are working together to try and solve these problems and achieve better health outcomes for people.
Thanks, Hugh. And we're nearing the end. And so I almost want to go back to the very first question that started, but I want to thank everybody for sharing your experiences and comments on the chat as we go along. We're thankful for that sharing that is going along. And some have noticed, I think there's a comment from Claire noting Donnella and Hugh, you might have a look at the comment around a Queensland project that is building on this approach. So one of the very first, in line with what Donnella says, my big questions was how might we design a better healthcare system or approach to the right to health in Australia? So if you had the ear of the Minister of the Health and you were pushing one or two things only that you want them to think about in terms of reimagining the right to health in Australia. Donnella, what would you be emphasising in that discussion? I don't want to make it easy for you just now that we're finishing by asking you easy questions.
So I've on a number of occasions heard Minister Hunt say up very loudly that our model of care, the Aboriginal and Torres Strait Islander Community Controlled Health Organisation Comprehensive Primary Health Care Model, should be a model for all Australians. So that is an example of the strength behind our model. Our model is, there's challenges within it, but what is so strong about our model is we see health through a lens of community, through spirit of person. It has so many cultural factors that enrich someone's health and well-being. So if I could just say that I've had the health minister say that to me directly at the NACHO last conference 2 years ago before the pandemic, that what his vision was that our model would be the model for all Australians to access.
Hugh, what would you be emphasising in terms of reimagining or improving the right to health in Australia?
I think governments should commit to the enforceability of the right to health. It's all very well to say in international law, we promise to uphold the right to health and the highest attainable standard of physical and mental health. We'll deliver on that promise in Australia, put it into Australian law, not just the right to health, all the interrelated rights, right to housing, right to education. Guarantee these in Australian law and hold yourselves accountable to the standards that you've promised to uphold.
Great point. And Rosemary, what would you be emphasising in this discussion about improving health and its understanding in Australia?
Look, I would say that it needs to be part of a very comprehensive, interrelated national disability strategy to ensure that it is an accessible public healthcare system that everyone can access, and that it has mechanisms that allow for the voice of people with disability to inform that. And it doesn't necessarily mean that it doesn't necessarily mean that it's a system that would be easily changed, but it's a system that needs to change, and we need to get to the point where it's so ingrained that people with disability are part of the community and so need to be part of the public health system, that maybe we can get away from these coercive, segregated systems that we've got at the moment.
And then there's a point raised by Yakubu in the chat where he says, is there a lack of curiosity and or desire to know more about human rights in Australia? And how do we change this in part? And I think by tuning in today, many of you are recognising that there is actually a curiosity, and it's broader than that. And some of you have asked in the chat about where you might know more about this. There is a campaign, as I mentioned at the start, around the Charter of Rights. If you go to charterofrights.org.au, you'll also have a look more information on the Human Rights Law Centre website about what the work that they've been doing on this and other rights. And we've also posted a link in the chat to the report we mentioned at the start, which is sort of a easy to understand, user-friendly report looking at what the right to health means in Australia, how it's currently implemented, and some examples of where it's not being addressed correctly. And I know we haven't got to all your questions, and sort of apologise for that. And you can, as always, reach out to particular people if you'd like to, go on with some of the issues that they've raised. But I would really like to thank your engagement in this discussion, and hopefully your engagement in the ongoing campaign around a Charter of Rights and how you might see that might be advanced in Australia, to get involved with that and go to the website and have a look. But particularly I want to thank the insights of the panel, Donnella, Rosemary and Hugh, for the really important insights that you've raised, questions around basic access to healthcare, the sort of the history of the lack of implementation, the lack of participation of First Nations people in designing this and sort of implementing this right, the siloed nature of this, the distinctions between physical and mental health, and also, you know, how a Charter of Rights might change that and how might improve it, and how we might actually, as Hugh says, get a remedy or hold accountable, that so that rights shouldn't just be aspirational. Rights have to have a remedy to be real, and that's really what we want to try and focus on in making the right to health a reality in Australia. So thank you very much for joining us today. Thank you for the panelists, and we look forward to staying engaged with you with this and for other seminars on rights. Please have a look at the charterofrights.org.au. Thanks so much.
Thanks, everyone. Thanks for hosting, Justine, and congrats to the students who wrote that report. It's a really great report.
Terrific. Thanks all.
Thank you.
Thank you very much.